y desde el momento que se empezó a gestar la idea no se nos ocurrió otro sitio en el que celebrar esta primera reunión, o sea que bueno, muchas gracias y a ver si con vuestra ayuda pues ponemos esto en marcha. Gracias. Okay, I am going to speak in English from now on. I hope that the Spanish patients and so forth are receiving the translation all right. Let's start with the scientific meeting now, and I'm going to chair this first session in the morning, and then we'll go on, we'll see. And we are lucky to have a number of wonderful speakers, and I think those in Europe really more knowledgeable on this disease are here, so thank you so much in advance to all of you for having come here, especially those who are coming from distant places. And with no further words on my side, let's please start, and with the Professor Antonio Federico from Siena. He has been working with this disease for many years, and so he will share his experience and that of his team with us. So Professor Federico, whenever you want, you can take your place. Thank you so much.
Okay, so first of all, I will thank you very much, Susie, for the organization of this meeting, and also the Spanish Society for Cerebrotendinous Xanthomatosis. That was the first society in Europe to collect the patient interest and to try to have a relationship between scientists, doctors and patients. And I was very much interested on CRER, and it was yesterday when I arrived in the afternoon a surprise for me to see this beautiful building and also this very nice and new organization that is, I think, one of the few in Europe. There are some private in Europe, and I have seen the Gresca Institute in Sweden that I know that is a kind of model of organization, but I think that in the South Europe is unique this, and I congratulate with you for this, and also for the government in Spain to have been able to organize this such a very interesting building and organization. So I will share, like an introduction, what is our almost 30 and more year of research and care on cerebrotendinous xanthomatosis that I consider a model of neurological disease, and as myself and Dr. Salen on 25 years ago, we published a paper, CTX as a model of aging. Is a very interesting model of aging, because all the findings of aging, cataract, problem of malabsorption, osteoporosis, mental problems, and peripheral neuropathy are present, but this is a reversible model of aging if we can treat as soon as possible, and if we can have an early diagnosis. So I will go through the history of this disease and also to have some clinical data for everybody. As like an introduction, this is a late onset familial disorders of bile acid metabolism with predominant neurological manifestation and a very progressive clinical course that depends. The history started a long time ago by Ludo van Bogert, who published on the 1933 this memoir that was the first description of clinical and neuropathological data in a particular case of dementia, ataxia and cataract that associate xanthomas in the tendons and after neuropathological investigation in the nervous system. This is Ludo van Bogert. It is a very beautiful history. Ludo van Bogert was the mentor of my boss, that was Professor Guazzi. So here is Ludo van Bogert in Siena, and this is a familiar, from a scientific point of view, history. Ludo van Bogert, my mentor, and myself when I was young. This was in 85, 86. So what is cerebrotendinous xanthomatosis? The clinical aspects are mainly characterized by tendons xanthomas, juvenile cataracts, and progressive neurological impairment that include peripheral nervous system, central nervous system with epilepsy, dementia, and so on. There is osteoporosis and bone fractures. There are some intestinal problems. There is a very large heterogeneity of clinical symptoms. And from molecular genetic aspects, there is a defect in sterol 27 hydroxylase gene with a deficiency of sterol 27 hydroxylases, and there is an increase of cholesterol and other bile acids. Is in the world everywhere diffused. We have a large cases on Israel that has been studied by Berginer, and they have been first of all treated by quinoleoxycholic acid since more than 50 years ago, in Italy, in Japan, in Netherlands, and we have here members of this group in Netherlands, in Spain. Then there are some sporadic cases everywhere, from Belgium, Brazil, Canada, France. France now there are a collection of patients, around 20, in Norway, in Tunisia, and Chile, and go on. Xanthomas. Xanthomas appear in the second or third decade, and we can have classical xanthomas of Achilles tendon. We can have xanthomas on the extensor tendons and elbow and hand, patellar tendon, as you see here, neck, and we have seen also xanthomas in lung bones and of course in the central nervous system. These xanthomas, from an histological point of view, are characterized by crystalline storage material that is surrounded by multinucleate germ cells with foamy cytoplasm. And this condition that is not always present, we will discuss later about the clinical heterogeneity. In 30% of cases, the xanthomas are not absent. This makes quite difficult the clinical suspicion. This combination, this clinical find is associated usually by a chronic diarrhea, so with an involvement of enterohepatic system that is very important, that is present early in infancy, that is the earliest clinical manifestation. This the enterohepatic system may be associated with gallstones that has been reported, and from a morphological point of view, the liver is characterized by amorphous material surrounded by smooth endoplasmic reticulum, mitochondria that appear as you see here, with a paracrystalline inclusion and increased number of peroxisomes. So we have an association of lipid dysregulation present in xanthomas, in liver with abnormality in mitochondria, and tendon xanthomas. They are the main clinical features, but very variable of this condition. A very important problem is the evidence of involvement of cardiovascular system and the link between cerebrotendinous xanthomatosis and atherosclerosis. There is a clinical aspect of a premature atherosclerosis or coronary artery disease that will be associated with high density protein, lipoprotein, abnormality, low ratio of cholesterol to lipoprotein B, and it is debated the evidence of heart symptoms that are present in interatrial or interatrial septum that may be the cause of a very marked heart problem that may be associated with this syndrome. And this is one Holdhauer article that reported that xanthomas may be present also in atrial septum in patients with CTX. So in the clinical diagnosis, it is very important to investigate the evidence of this lipomatous hypertrophy of atrial septum that may have some problem in the management of these patients. So heart problem, nephrolithiasis and nephrocalcinosis is also present and have been reported in several cases, showing features compatible with incomplete renal tubular acidosis type 1. And here we see our large pedigree in which these findings may be associated, and we open later a problem also of the presence of minor clinical signs in carriers, and this is one of the reasons that we consider very important to have a large registry for this disease to investigate the problem in carriers. The skeleton is involved, and we know that bone involvement with granulomatous lesion in lumbar vertebra and femur with osteoporosis, increased risk of bone fractures that is related with a decreased total body densities and impaired absorption of radiocalcium that will improve after chenodeoxycholic therapy. This is a similar condition that may be present in some chronic liver disease and is related to the impairment of intestinal calcium transport that lead to osteopenia. This was the first paper that we published more than 20 years ago no, this is 10 years ago, on the bone changes after chenodeoxycholic acid and the relationship with vitamin D status. The ocular findings are very important. Cataract usually is the first symptom that will appear in infancy around the first decade of life and is related to the higher level of cholesterol that has been reported in the lenses with cataracts and is this corneal opacity has been also demonstrated in experimental animal that has been feeding with cholesterol-rich diet. We have evaluated in a large number of patients this, and we have seen that there are changes in optic disc pallness, retinal vessel sclerosis. It is a cholesterol-like deposits, and also in optic nerve. You see here the abnormalities in optic nerve that are on the basis of an arteriolar narrowing and venous changes in the optic disc and at fundus eyes. Endocrine abnormalities are very important. Occasionally, hypothyroidism has been reported, and this suggested a long time ago when we organized the first meeting on late onset neurometabolic disease in Siena in 1991, that we described this disease as a multi-system disease mimicking premature aging. Cerebral fluid, that is a good marker of what happened into the brain, reported since long time ago a defective blood-brain barrier permeability to the high level of cholesterol and cholesterol and elevated concentration of lipoprotein B. It was present higher level of lactate involving an abnormality in mitochondrial functions, and these abnormalities will improve after chenodeoxycholic acid therapy. But now we have new markers for investigating cerebrospinal fluid that has never been approached to the investigation of CTX. For instance, we have ApoE that has been done, but also other proteins that are tau, phosphotau, protein tau, and other linked to neurodegeneration that may be a useful marker to investigate the neurodegeneration in those patients secondary to primary change in cholesterol abnormalities. But the big marker for this disease is central nervous system that is associated with mental retardation or mental deterioration that lead to dementia, psychiatric symptoms that are constantly present with behavioral changes, hallucination, agitation, aggression, depression, and suicide attempts that are constant. We will discuss this, how is the hypothesis on the basis of these psychiatric symptoms. Neurological involvement that is related to two main neurological markers. The brain with cerebellum, but also white matter and neurons, and the spinal cord. We will have pyramidal and cerebellar signs that are constantly present. We may have extrapyramidal manifestation with dystonia and Parkinsonian syndrome. We can have epileptic seizures, and we can have also one very rare signs that has been reported, first of all, by Ludo van Bogert, the palatal malglorus in the original family, that he mentioned as a classical finding, but we have seen not very frequently in our case, but also in other literature report is not very frequent. But this is very interesting and localized neurological changes in a special part of the brain. There is also a vulnerability of peripheral nervous system. You know that peripheral nervous system and also Schwann cell are different by astrocytes and neurons in the brain, and Schwann cells are very vulnerable to cholesterol abnormalities, and we have a chronic neurogenetic pattern and decreases sensory and motor conduction velocity that is suggestive of a sensory motor neuropathy with an histological findings that show demyelination and remyelination related to axonal degeneration or both. You see here marked axonal loss, onion bulbs, and electron micrograph of Schwann cells. A very interesting paper was this one that is reported 2 years ago, that linked the chenodeoxycholate to NMDA receptors and GABA receptors, and this paper, that is a basic paper, report a link as a potent antagonist at MDA and GABA receptors of chenodeoxycholate. So if we have a lack of this substance, we will have a change in the pattern of several neuroreceptors, and this could be one of the hypothetical bases of the very special neurological involvement in such patients. But we will have also muscle involvement that from a clinical point of view is characterized by myopathic changes that from a morphological point of view we reported changes in fiber size and mitochondrial aggregates with paracrystalline fibers. You see here this particular on the here mitochondrial shape that are very severely altered, with an increase of lactate that is higher in patients, and that is linked also with some respiratory chain enzyme activities changes that show a decrease in cytochrome C oxidase. So we have a secondary mitochondrial dysfunction related to the abnormality in bile acids that will improve after chenodeoxycholic therapy. We know very well what is the brain changes in such patients. That is reported in many papers from our group, from the Dutch group in Netherlands, characterized by diffuse cerebral and cerebellar atrophy, cerebellar bilateral focal lesion, brainstem atrophy, high signal in globus pallidus, and leukoencephalopathy. What is very typical is this cerebellar abnormalities that is very frequently found and reported as early also in all patients. We try to investigate the relation by MRI spectroscopy, the link of several metabolites and disability of the patients, and we see that there is a ratio of N-acetyl aspartate, lactate, and disability. As severe is disability of these patients, there are the same number that N-acetyl aspartate is altered. And also we evaluated brain volume by a measurement of the total volume of the brain, so the brain atrophy and the different part, cerebellar and different area of the brain, the atrophy, and we have found that there is changes that are linked with MMSA and the disability scale. But it was also reported that it is a progressive cerebellar vacuolization during the time, and you see here this slow evolution of MRI findings that are evident during the follow-up of the patients, while cholesterol and other metabolites are quite stable. So we will discuss in the general discussion, this is one of the points, which is the link between biochemical findings and progression of the disease. And I think this is one of our goal to discuss in our network, if we will be able to organize an European network on this disease, to try to collect data on the clinical variability and on the some question marks that are still open. As I told before, the new markers in CSF are lacking in cerebrotendinous xanthomatosis, and recently has been reported a very interesting article of a premature aging limbic tauopathy associated with a mutation in typical of CTX. So it is possible that a link of this mutation with abnormality of protein tau and amyloid protein is present and will have some role in the clinical phenotype of disease and in the neurodegeneration and apoptosis. So I am a clinician that love very much basic science, and to consider rare disease as a useful model to exercise our mind in investigation. And I think that starting from this very interesting disease of a limbic tauopathy associated with this mutation, we can enter into the problem of neurodegeneration, and we know that many oxysterols and other markers are involved in Huntington disease and in many neurodegenerative diseases. So we can open a window starting from this disease to investigate the role of protein tau, beta amyloid, and other protein related to neurodegeneration. What is neuropathology of this disease? So is abnormalities with extensive changes in cerebellar white matter, with astrocytosis, lipid crystal cleft, extracellular deposit of myelin-like material, and demyelination and perivascular accumulation of macrophages that are involved to lipid storage of material. Long time ago, Menkes discovered the cerebellum in the cerebellum the accumulation of cholesterol, and the pathogenesis of this disease has been related to bile acids abnormality, and